Case study 1. This patient who presents in a forties has lips which are similar to the M shape we see often in younger patients, and the technique will follow a similar strategy. But let's look at her holistically through the lens of the 8D approach. Remember, patients have not been trained in the 8 dimensions of lip design, so it will never come out neatly in the order which we have in our proforma. We must have the questions in our minds and assemble the answers, which usually takes 3 to 10 minutes. We need to establish the 5 foundational dimensions. These are the patient's real motivations, their hopes and fears, how they want to look, feel and behave, and what they are afraid of with respect to the procedure and the outcome. Until you understand the hopes and fears, you are designing in the dark. How did this patient want to look?
Yes, I've just noticed that my lips are starting to lose a little bit of volume and definition around the corners of the mouth, and it's just something I'm looking to improve. I've just noticed that the upper lip especially just feels like it's lost its volume and it feels flatter, and I just feel a heaviness around the corner of my mouth.
And the wording that she used in her request and her overall appearance made me suspect that she is more certainty-driven, introverted and cautious in her aesthetic goals. This request fits mostly with a restorative approach rather than a big change, but she is interested in the possibility of beautification as an aesthetic goal too. How does she want to feel?
Just improved confidence.
And on probing, also to feel more attractive, although this was not something that came out as a first request. Of course, we all want this, but it helps so much to have it said out loud. Older patients are often more afraid of asking for these positive outcomes, possibly because it reveals a vulnerability, especially in front, in my case, of a man.
Everybody wants to feel those things, but that's not the primary aim for me.
But also, they have a fear, I believe, of disappointment. It is easier to ask for a correction than it is to ask for beautification. But I assume every patient wants this. What does she want to do? The social goal.
So I guess I work in quite an important role, and I deal with the public a lot, and I deal with many professionals, and I feel like I have to look fresh and my best all the time. And with natural aging, you notice that a few of the aspects of your appearance seem to deteriorate, and that's definitely what I've noticed.
Where there is a possibility of interpersonal conflict due to the frequent requirement for boundary setting, the confident and strong person actually is less likely to have a fight over boundaries. Like many, she had detected that the aging process felt like a small chink in her armour and therefore wanted to have it corrected. Procedural fears. Was there anything that she was afraid of during the procedure?
I think it's hard to put into words, really. Just obvious, unnatural looking lips, which is what I don't want.
Yeah.
But I don't want under-treatment either.
This patient was indeed afraid of complications. A certainty-driven person with respect to medical interventions, she was reassured simply by my experience and all the social media content which I've produced.
The only thing that would worry me is having the procedure in unsafe hands, which I know I'm not.
Remember, not everyone will be, and here is where you need to design the procedure to overcome these fears, as well as teach and explain how you will do that to build trust and confidence with the patient. Interestingly, she was not afraid of post-procedure swelling and bruising due to the ability to wear masks at work at the time of shooting. This gives us a greater degree of freedom in terms of the techniques we may choose. Aesthetic fears. Her primary concern was over-treatment and looking unnatural. This is typical of most certainty-driven patients. Interestingly, it emerged after some discussion that her secondary fear was that she would not be able to tell the difference. Many patients allow their fear to be the loudest part of the consultation, and only when some trust is built do they let you know what they really want. She wants to feel more beautiful, a bit special. She probably doesn't like to say this out loud, but it is a normal human need, and by discussing it, I build rapport, and we can therefore build a better design for her to maximize the chance of this outcome. Aesthetic analysis. Let's examine the patient through the 8 aesthetic dimensions. First, volume. Many patients refer to volume when in fact they are actually more referring to the proportion of the lips. For me, volume is around shape, roundness of the lips. When we look at her lips, we can see that they are relatively flat, particularly in the top lip, but there is good volume in the medial part of the lower lip. It's this flatness, particularly visible in the profile view, that hints at additional volume being required, and often goes with flattening of the philtrum and decreased projection. The next dimension. Projection is defined by the ability of the lips to project beyond the facial plane, which is a line that runs typically through the nasion and the menton of the chin. Her lips, I would say, are relatively unprojected. There is also a top lip to bottom lip ratio which is less than ideal. Usually we want the top lip to dominate over the bottom lip in profile view, so this gives us an additional area of room where we can add volume and beautify at the same time. Proportion. A useful guide to beauty is to use the golden ratio for proportion. In terms of proportion, her lips are relatively small. The foundation ratio is the intercanthal distance, and we can see that a ratio of 1 to 1.618 would make the lips wider than they currently are. So there is an area here where if the lips become wider, she will also become more beautiful, and this is attainable with most augmentations, 1 to 2 millimeters, but that does make a good aesthetic difference. The position of her lips, proportion-wise, also reveals a disharmony. Ideally, the chin and philtrum fit the golden ratio approximately, particularly in females. In her case, her chin is relatively small and her philtrum relatively long. By more significantly augmenting the top lip, we will actually help correct this ratio somewhat. We can elevate the vermilion border, show more pink in the top lip, adjusting the top lip to bottom lip ratio, but this will also add to an improvement in the overall ratio of her lower face. You can also assess the top lip to bottom lip ratio using the golden ratio, but this is much more variable. Many patients have a 50-50 split, but certainly a dominant lower lip is not considered ideal, so increasing her top lip volume will also be indicated looking at the ratio from the perspective of the lower lip. Details of the lip. She has lovely details, a good philtrum, good top lip angles, Cupid's bow, and she has a lower lip angle, which approximately fits along the philtral column to the angle of the chin. It may be slightly medial, which could be something we can use to design a better result when treating her lower lip. If we can widen the lower lip angle, this could add some harmony and beauty to her face too. Definition was the patient's primary presenting complaint, and particularly with respect to the top lip, and you can see this in profile most clearly. She has lost the projection of the vermilion border, and this has created a straighter philtrum, and she is requesting that we redefine the vermilion border so that it becomes a more dominant structure, particularly in the profile view, which fits neatly with the other reasons we have to treat the top lip more significantly than the lower lip. Definition in her philtral columns is good, but almost certainly less than it used to be. Angles of the lip include the lower lip angle, which is ever so slightly blunted, the overall angle of the lips, the oral commissure, which is also more acute than it would have once been, and the angle at the Cupid's bow, which is relatively good. In terms of symmetry, she has some common asymmetries. There are small differences in the surface of the top lip, which may become more important as time goes on if we do augment her lip. Particularly, it's the shadow that runs laterally, more so on her right side. You can also see a small shadow in her top lip in the profile view, which could be exaggerated if you were to treat the lips in isolation. These small observations would also fit into the category of distractions later on. So things that simply do not belong, that distract from our beautiful pink lips and eyes, which should be the main features of the face. So little shadows that disrupt the ability of those structures to dominate often warrant small treatments to blend them in to get more beautiful overall results. So let's now discuss the treatment plan. Although this patient was afraid of complications, she was not stressed at the time of treatment and trusted me in my ability to deliver, which gives some degree of flexibility in terms of how to design the plan. She was not afraid of injections. She reported having a good to high pain threshold, and this gives a degree of freedom in terms of how to treat. I can simply focus on what I believe will get the best aesthetic results, given that the overall risk with an experienced injector is relatively low. So I can see in this close-up shot some of the disruptions we will face as we do the procedure. Small areas of fat loss that may become worse as we treat the lip higher up. To treat definition, we're going to need to do horizontal injections, lateral on the top lip. I estimate one 0.05 mil injection for each length of the needle. At the same time of doing this, I will need to correct this indentation here, which forms the more M-shaped lip. So I would do a first pass of two 0.05 mil injections on each side, and then 0.05 laterally. Because I can see the lost volume in the center of the lip, I'm also going to recommend treating certainly the lower third of the philtrum at the same time, with the hope that in the profile view we get a little bit of that U shape of youth, which forms underneath the nose with projection of the top lip. To harmonize the lower lip, I'm going to recommend some treatment in the lateral aspects to fill these missing areas of volume and to balance the relative strength of the mid-lip with the lateral lip. 2 sweeps of 0.05 mils should make a noticeable difference. I'm anticipating adding a little bit of volume in the top lip as we project the pink lip higher up. So 0.05 mil linear threads in any shadows that form, with some supporting filler here where the fat pad runs up against the insertion points of the muscle into the white lip. This will be a 0.05 mil injection. If on assessment during the procedure, this looks like a weak point. To increase the chance of treating the M-shaped lip effectively, we may need to add additional volume and vertical height with 1 or 2 vertical injections entering at the vermilion border to elevate the indentation of the middle lip, and to add additional volume in the top lip, which we know is of high importance in the overall end result of this procedure, both in terms of volume, projection, definition, and proportion. So now I'm going to elevate the medial 2/3 of the lip. I want to enhance the vermilion border and increase the top lip volume and height. So I'm sliding the needle in just underneath the dry mucosa, up towards the GK point. The needle tip is right underneath the GK point. I have aspirated, and then I'll do a linear thread of 0.05 mils, not come all the way out, because I'm now going to change angle and slide back in inferior to that first injection. So I'm stacking 2 on top of each other, which together will enable the medial part of the lip to be elevated. So we're adding volume and a little bit of eversion to the lip with 0.05 mil components. I'm going to repeat it one more time. And most of the product should be in that anterior compartment. That's nearly always where we're aiming to be. You can see the filler coming out, flowing into the low pressure zone, so this lip will need a little massage afterwards. Here we can see the same injection in 3D. Note the position of the needle anterior to the insertion of the orbicularis oris muscle, which is the key safety feature and is why we reduce the risk of migration injecting on this side of the lip as a general rule of thumb. But you can see that elevation is very clear, and that's my goal. Laterally, I'm repeating the process, different volume of injections, but we're going to add 0.05 mils along the vermilion border, right up against where the muscle is inserted. I'm not actually into the insertion point. This is exactly the same concept laterally. We are just injecting 0.05 in the same style with the same reference point of the insertion point of the muscle. We should still be anterior and inferior to the artery. A depth check and aspiration can confirm this. Next, I am filling those little shadows, which are now enhanced by the support I've created in the pink. So when you create volume in the pink lip, it often reveals the weaknesses in the white lip. And so I'm doing a small amount of product to resist that and to keep the simplicity of the lip, so we don't have new shadows forming and, even worse, new creases. These injections are all in the hypodermis above the muscle. Looking at the same injection in 3D, the important points to note are that we are above the muscle and we are consciously mainly controlling depth. Just underneath the dermis, we're at probably the superficial aspect of the hypodermis here, which is a place less likely to bruise, certainly than if you were to pass anywhere near the muscle, where arteries and arterioles are most likely to reside. Next, we're going to do a vertical injection. Now, I sometimes find it helpful to create a small curve on the needle so that it's easier to follow the shape of the dry mucosa, particularly when you're more medial and you're going around the projection of the nose. Please note the entry point here is very clearly just on the pink side of the pink-white border, which is our safety area. We are less likely to injure the artery, less likely to have pain, and it is a good starting point. Also note my supporting hand is rotating the lip up, which makes it easier to find the right entry point and to enter at the right angle. So we go all the way in until you're about 2 millimeters from the wet-dry border. And then a linear thread of 0.05 mils, stopping your injection just as you're about to exit the lip. I'll do a series of these. I'm trying to stay very superficial, which is what I can do with this particular product. There, as you can see, sometimes you do come out and keep injecting. A little massage will solve that. And I'll repeat injections until I feel like I have the aesthetic result that I'm pursuing. Note the entry point into the pink lip, passing down the anterior wall of the lip. We are staying in the anterior compartment the entire time. We are relatively close to the dry mucosa surface, but we are in the connective tissue part of the lip. We are not in the body of the lip, which is why we get an increase in vertical height. We're very careful not to pass through the wet-dry border, and it's a linear thread of 0.05 mils per pass or less. Now I'm treating the philtrum. It's important here to note that entry point. I'm entering through the pink lip. This is dry mucosa, and then entering into the space, the hypodermis, underneath the philtral column. I do a little squeeze to keep everything straight, and a 0.05 mil linear thread after aspirating. It is an area that commonly bleeds. Let's have a look at that again in 3D. Note that entry point right at the apex of the Cupid's bow. We're still in the pink lip. We're diving underneath the dermis, but not into the muscle. We should only cross a small amount of muscle near the insertion point, and then we should be in hypodermic fat. To make this easier, a little squeeze of the philtrum to line things up so that your straight needle can pass into a straight structure instead of a curve. Now we are treating more of the white lip, where the elevation in the pink lip is revealing the weakness in the white lip. So you get a small shadow and a disruption or a distraction. So 0.05 mils, very small amounts with this very gentle product, and that will blend in those small shadows and prevent lines from forming. We now repeat the same on the other side. So your defining injection, 2 millimeters down from the insertion of orbicularis oris, we enter, slide the needle up, 0.05 mil bolus, then a 0.05 mil linear thread. Then we change angle, go slightly inferior to that injection point to add more volume and roundness in this stacking/fanning style of injection, which decreases the number of entry points. And then the lateral injection, where we also do 0.05 mil. I'm doing a little depth check there, aspirating, and then a linear thread on the way out. We also simplify the other side of the lip, so this little shadow needs to be softened. As you can see, I'm doing a depth check to make sure that I'm above orbicularis oris. You don't want to be putting your needle through the muscle, which is a risk for bruising, and obviously closer to the artery. So a little depth check, superficial injection, and now I'm checking to see how that has impacted the lateral lip. So there is this natural weak point, which we talk a lot about on the course, where there is no longer an attachment to the white lip and the muscle. And if you don't reinforce this, this often forms a new line that comes 2 to 6 weeks after the initial procedure. Let's recap from our anatomy module. Remember, we have connections from the fascia of the muscle all the way through to the dermis, which then fade as we move laterally. So there is no longer direct connection between orbicularis oris and the surface of the skin. And at this point, there is a weakness in the skin, which means if you strengthen the lip, you can sometimes cause a new crease to form, causing a shadow just lateral, just superior to the oral commissure. We can defend against this with one injection of dermal filler, usually around 0.05 to 0.1 mils. Now it's time for the lower lip, and we are going to inject laterally only because the middle lip is actually quite dominant. So if you remember from our treatment plan, the plan is just to do lateral volume. We'll do 0.05 mil linear threads and replace some of the lost volume to create a more harmonized lower lip. This decreases the sense of sadness that sometimes you see in patients just to lift laterally. And now we're treating the other side of the philtrum. Depth check, everything straight in position at the right level, 0.05 mil linear thread, little bit of a shaping squeeze, and we're done. Please note, I have not presented these before and after photos as you might do on social media. There is no lip gloss and no makeup. There is some visible redness from the procedure. And this is just to show you a technically accurate result rather than what you may use for marketing